And good afternoon, everyone. The summer break is over. Our producers are back at work, and DeBakey CV Live is live again. It's Tuesday, it's 5 o'clock. This is the second Tuesday. Normally we're on the first Tuesday for atrial fibrillation or AFib talks. This month we moved it to the second Tuesday. Hopefully many of you got that memo. It's also on Facebook. It was sent out on Facebook. It's good to be back after the summer break, and we've got a lot to talk about. This next 45 minutes to 60 minutes, we'll be talking about minimally invasive approach to AFib. There are different minimally invasive approaches, and I'll make the case for the different ones. Try to explain it to you in lay terms. And I want to mention from the top of this hour, you can join me with a question in the web or by text. If you have your phone, that's on the right of the screen, you put in 37607, and then you, in the text box, put DeBakey, and you'll be able to text in your message. So we will take questions. Please send your questions as soon as possible, so that I might get to them before the end of the show. We will intersperse the questions as we go along this hour of CV Live. So don't wait. The sooner you get them in, the more likely your question will be addressed. And if you're on a laptop, you go to pollev.com, enter the word DeBakey, and then respond to the activity. And we'll put those up from time to time. If you missed that. I welcome questions. There are no inappropriate questions as long as it's about AFib or something that we do, and we'll try to answer all your questions. If you're interested in a consultation for your AFib, that's fine as well, and you can go to wolfminimaze.com. That's my name, WOLF, then minimaze, MINIMAZE.com. And there is a way to sign up for a virtual or in-house consultation. A lot of our consultations now are virtual, and that's fine to get started. Someone from our staff will contact you and set up the virtual visit. We do 20 or 30 of them a week. It doesn't obligate you to come to Houston, doesn't obligate you to have any AFib procedure here, but it can serve as a second opinion if you're suffering from atrial fibrillation. Minimally invasive AFib surgery, what does it mean? Well, first of all, it means we're not going through the breastbone like traditional surgery. Traditional surgery is done through the breastbone on the heart-lung machine. Now, there are several variations of this. The procedure that I have performed now for over 20 years is called the mini maze. It's not really a maze, but it got that name, just like robotic surgery today is not really robotic surgery. What does it include? It includes no sternotomy, no heart-lung machine, going in with the scope through the sides, plus another incision, a working port. At the end of the procedure, the patients are awake. We did 2 cases today. Both patients were awake on the table. They went to the recovery room, and then they went to the regular floor. So it does not include a stay in the ICU unless there's some unusual situation with the patient. And it includes a 2-day stay, usually in the hospital. The key of the mini maze is to treat the nerves. And as many of you know who've been on here before, we have a very convincing argument that it's the nerves on the outside of the heart that initiate and sustain AFib. And if those nerves are not addressed, if they're not isolated, the chances of really being free from AFib for 20 years is quite small. But with the mini maze, it's quite large. And I have patients out over 20 years who've had the mini maze procedure, have had no more AFib on no medications. Last Christmas, one of my patients took me to lunch. He wanted to celebrate. It was an anniversary of his mini-maze. He had been in atrial fibrillation continuously. His ejection fraction, the function of his heart, was way down. It should be 50 or 60%. His was 15%. They were talking about a possible heart transplant. And he came to me and said, Dr. Wolf, I believe my problem is AFib, and I think it's a nerve problem. He had had previous coronary bypass surgery. He said he went into the hospital with AFib. They did bypass surgery. They didn't know anything about his AFib. He went out of the hospital with AFib. So he was about 2 or 3 years out from the bypass surgery, AFib, low ejection fraction, had the mini-maze. And now has a normal ejection fraction. He's on no medications, and he's in rhythm. His mini-maze was done 22 years ago. That's right, 22 years ago, and he wanted to celebrate the anniversary with me. He was 65 years old when I did his procedure, and now he's 86 years old. So that's long-term follow-up. We have many of those. And I think the reason it works is because we attack the root problem, which are the nerves on the outside of the heart. Years ago, this is 15 years ago, we did a study here in Texas Medical Center where we looked at the ultimate procedure to denervate the heart. With the mini-maze, it's a partial denervation. But we looked at the ultimate procedure to denervate the heart, which is a heart transplant. With a heart transplant, you take the heart from somebody else, all the nerves have been severed. So that's the penultimate nerve denervation. And we looked at patients who had heart transplant to see what their post-op AFib rate was after heart transplant. Because I predicted it would be very low because the nerves were affected. It was a denervation procedure. And in fact, that's exactly what happened. We saw an extremely low rate of AFib after heart transplant, 2% in almost 500 patients. So, pretty amazing. Now, with catheter ablation, the burning is done from the inside of the heart. The inside of the heart is all muscle. There aren't any nerves there. From an anatomic standpoint, the nerves are mainly on the outside of the heart. And the only procedure that really focuses on the nerves around the heart for AFib is the mini-maze. Today, one of the patients was a retired general surgeon, and he has persistent AFib. His wife underwent the mini-maze 4 years ago. She had both inappropriate sinus tachycardia and AFib. So whenever she got a little bit excited, including white coat syndrome, her heart rate would go up to 140 to 150, and she was incapacitated. 4 years ago here at Texas Medical Center at Methodist, she had the mini-maze procedure, and she's been completely free of any arrhythmia, any fast heart rate last 4 years. Her heart settled down. She feels 1,000% better. She's on no medications. One other thing I learned was after doing this for many years, patients would come back and say, I feel like I did 10 years ago. And I thought, okay, well, you're in rhythm, but you feel better than you did. This is the best you feel, almost like you felt well 10 years ago. What is that? Well, I think what it is half of it is getting back in rhythm, and the other half is getting off all the medications. Because most of the medications for AFib are strong medicines. They may slow the heart rate, but they also slow you. You become very tired. It's difficult to do the things you love to do. So it's not only getting in rhythm, it's getting off the medications. And with the mini-maze, you get off medications. The mini-maze procedure focuses on the nerves on the outside of the heart. It's called the epicardial, or outside the heart area. Catheter ablation focuses on inside the heart and burning the heart muscle. It doesn't have as good a track record with long-term results, particularly if the patients are out of rhythm continuously before the procedure. There's another procedure that's called minimally invasive AFib surgery, which is called the convergent procedure. The convergent procedure depends on two things. One, a catheter ablation, and then two, a surgical procedure where the back of the heart muscle is burned from the outside. The issue that I have with the convergent procedure is it still depends on the catheter ablation to do part of the work. And catheter ablation burning from the inside is much more difficult than burning from the outside. And the outside burn of the convergent does not really focus on the nerves. It simply focuses on burning the back wall of the left atrium. Unfortunately, I've seen many patients who've had the convergent still have AFib and are still looking for an answer. Another procedure, which is called minimally invasive AFib surgery, is going through an incision on the right side of the body while the heart is on the heart-lung machine. So tubes are placed in the groin, arterial line, venous line, that's artery and vein. The heart-lung machine, the patient is heparinized, in other words, the blood is thin. Go on bypass like open heart, but then the access to the heart, instead of being from the breastbone, is over on the right side. So it's minimally invasive in the way that it does not go through the breastbone but goes between the ribs. But it's still invasive in that the heart-lung machine is utilized and the heart is open, so it is truly open heart procedure. And that's called a Cox-Maze 4 minimally invasive procedure. The Cox-Maze procedures work, but I don't think they work because it's a maze procedure. I think it works because a lot of the nerves are disrupted on the outside of the heart, and it's a pretty good partial cardiac denervation, and that's why it works. But it's not necessary, in my opinion, to go on the heart-lung machine to live AFib free. Let's see. Maybe we should take a couple questions. A little bit of the line is off the screen for me. Okay. Hello, Dr. Wolf. Here are a few of the questions I haven't seen in the Facebook group. I would prefer not to have a foreign object in my heart, but to have my LAA removed altogether, but I was told clipping is faster and safer. I'd like to understand why exactly. What are the risks of having it removed? What's the difference in terms of efficacy between removal and clipping? The AtriCure website, and this is the devices I use are from AtriCure. I designed several of those devices. And in fact, early on, 24 years ago, there wasn't any AtriCure. When we made the device, the company was Enable Medical, and then AtriCure was spun off after we made the first clamps. The AtriCure website says the AtriClip provides immediate isolation of the left atrial appendage during surgery, called acute isolation, while saying that further studies are needed to confirm permanent isolation, called chronic isolation. What makes you so confident that the mini-MACE patients can safely stop taking blood thinners and aspirin? What is the stroke rate caused by blood clots originating from the LAA? Well, let's see. Let's take these questions one at a time. So, Mr. Producer, go back up just a little bit there. Thank you. I did two cases today. One patient from Florida, one from about 3 hours. No, one patient from Arizona. In both cases, we closed the left atrial appendage with the AtriClip. It's kind of a big hair clip, and it closes like that. It's made of titanium, and the body doesn't react to titanium. But not only do I close the appendage, then I cut the tip of the appendage off, remove it, and there's no blood coming out. So it is completely isolated at the time of the procedure. There's no question about it. You want me to move back over a bit? Okay. Make sure I can't block the Methodist sign there. So in my mind, It is completely occluded. There's no question about it. The first 1,000 patients I did, I removed the appendage because we didn't have a clip. And then the first clips were a little crude. I didn't think they were really ready for prime time. So I removed over 1,000 appendages. But it's a stapler, and they're titanium staplers. So either way, you end up with a little bit of titanium in your body. So when you say I prefer not to have a foreign object in my heart, you have to have something there. You can't just cut off part of the heart and leave it flap open. It's got to be closed. And the safest way to close it, if you do have it removed, is with titanium staplers. I'm the one who started that. So I did that for a long time, over 1,000 cases. And it is true that the clip is a little faster, it's a little safer, and a little easier. But the end result is the same. After the appendage is clipped, the appendage turns into just a little scar. And we know that because a baboon study was done before the clip was used in humans. And at 6 weeks, the appendage is atrophied into just a little scar. So it really doesn't matter, I don't think. So why not do what's a little bit quicker, a little bit easier, and a little bit safer? The immediate isolation, you get electrical isolation within 10 minutes with the clip, and that's fine. Let's see, now let's go down just a little bit. What makes you so confident that the mini-maze patients can safely stop taking blood thinners and aspirin? Well, the main reason for taking blood thinners is to decrease blood clots in the heart when the heart's out of rhythm. And the main place where blood clots form when the heart's out of rhythm is the left atrial appendage. So if the left atrial appendage is closed, that should decrease the stroke rate by about 97%. Nothing's 100%, but 97% is very good, and that's without taking any blood thinners. Taking blood thinners is a risk. Taking aspirin is a risk. And the last study I saw on AFib showed that if you did have a stroke and you were on aspirin, it was a lot worse stroke than if you had not been on aspirin. Secondly, I remember one patient very well. He came into my office. He had a baseball cap on. He sat down and said, "I'd like to have the mini-maze for my AFib." And I had looked him up, and I said, "Well, I know you came here 3 years ago, and we discussed anticoagulation versus mini-maze, and you decided just to take blood thinners, which is fine." He said, "Yeah, but I was up on a ladder. I fell off the ladder. I hit my head. I had a brain bleed. I had emergency neurosurgery." Then he took off his baseball cap, and you could see where they'd gone into his skull to get the blood clot out. And he said, "I realize now that it's not safe to take these blood thinners." And that is not an unusual scenario, maybe not a ladder, but people fall down, they hit their head, they bleed into the head, much more if they're on a blood thinner. So there are significant risks for being on a blood thinner. For every medication, it's risk versus benefit. What's the risk? What's the benefit? If the risk is higher than the benefit, you shouldn't do it. That's true for anticoagulants too. So anyway, he had his mini-maze and did well, and now he doesn't take blood thinners anymore. What's the stroke rate caused by blood clots rising in the left atrial appendage after the mini-maze? Well, there have only been 3. We've only had 3, and we can't even prove that those blood clots came from the left atrium, because 85% of strokes are from something else. 15% of strokes are from we think atrial fibrillation. So, but we called them strokes, and we reported them as strokes after the mini-maze. That's 100 times less than the stroke rate for a catheter ablation. Another study that we did, and it's now in abstract form being submitted for publication, is we looked at patients who were having catheter ablation with a special ultrasound device over the carotid arteries. Now, the carotid arteries go up into the brain, supply blood to the brain. During catheter ablation, there were 2,000 to 4,000 little pieces of stuff leaving the heart and going into the brain. 2,000 to 4,000 either air emboli or particulate stuff breaking off from the catheter ablation going into the brain. That's one ablation. We had a patient several months ago who had 8 ablations. They told her she'd never be in rhythm again, by the way. They told her not to come to Houston. She did anyway. She'd had over 30 cardioversions or shocks to the heart. They told her she'd never be in rhythm again. The clamp, I placed the clamp and closed it and fired it one time, and the heart went into rhythm spontaneously. Didn't have to do a cardioversion. But anyway, we also tested this technique of looking for pieces of stuff going into the brain during the mini maze and clamping the left atrium with the mini maze. Now, catheter ablation, we know, is 2,000 to 4,000 little pieces of stuff going into your brain, which I think, by the way, is what causes the post-procedure headache after catheter ablation. What did we find in the mini maze? Big fat 0. There weren't any emboli. That's a big difference. So I'd be more worried about that than what type of closure you have of your appendage. Here's another question. How is the 85% success rate for persistent AFib estimated? That's estimated from a retrospective review I did of my own cases. That was published about 8 or 10 years ago, and it was over 100 patients that we looked at. Are they based in follow-up with patients? Yes, of course, and that was out to 6 years after surgery. Are the ganglionic plexi nerves always ablated during the mini maze? Yes, they are always ablated, only if they are misfiring. No, they're ablated, and we also check them after we ablate them to make sure they're not misfiring, but we always treat those just by putting the clamp on and closing it around the veins, really up on the atrium, left atrium. That takes care of almost all the ganglionic plexi, except a few here and there around the left atrium. So even just putting the clamp on gets 80% of them. Is the link monitor always inserted for persistent AFib? The link monitor is a implantable loop device, so it's a loop monitor. It's what it does is it records, it looks continuously at your EKG, and if it sees a unusual change or a pathologic change in the rhythm or the rate, then it sends us a message. It also sends us an EKG every day. So it's an implantable loop monitor, or implantable loop recorder, I guess I should say. Implantable loop recorder. And the battery lasts about 5 years, and it works through your cell phone. So the signal goes from the loop recorder under the skin to the cell phone. It's not inside your chest cavity, it's just under the skin. And it downloads one every day and sends it to us, and I can see that on my phone. The link monitor is inserted for all types of AFib. It doesn't matter. It's particularly helpful for persistent and long-standing persistent AFib because most of those patients have not been in rhythm for a while and they're on antiarrhythmics. And if they stay in rhythm after the mini maze, we'd like to wean them from the medications. And the best way to wean a patient from the medication is to decrease it and look at the link and make sure they're staying in rhythm. In addition, a lot of patients come here from around the country, around the world. We did a patient from Melbourne, Australia a couple weeks ago. And it's very nice to be able to see their EKG every day, no matter where they are in the world. They don't have to go to the cardiologist. They don't have to go to the emergency room. We see their EKG every day. And it also, the link also gives us a very interesting little bit of information. That is, it calculates the AFib burden per month. So in other words, every month, the link monitor will tell you what percent of time you're out of rhythm. Is it 5%? Is it 10%? Is it 100%? And after the mini maze, we want to see it go down to 0. In fact, we are doing a retrospective study now. It was approved. The IRB approval process is complete here at Methodist Hospital, and we're looking at several hundred patients who've had a mini-maze, who have a link in to look at the AFib burden. So we think this is going to be very helpful. And looking at the preliminary, the results look very promising. So I think we went through that long question. What's the next question? I don't know, can you make that a little bit bigger? There we go. But patient, thank you. If you have both atypical flutter and AFib, does your procedure fix both? Yes. We never saw atypical flutter until catheter ablation. Atypical flutter is pretty much an iatrogenic problem. So burning in the left atrium produces what left atrial flutter, also called atypical flutter. Typical flutter, which has been seen by physicians and cardiologists for years and years, occurs in the right atrium. The right atrium. But atypical flutter occurs in the left atrium, and most commonly is after a catheter ablation. So it's more common in patients who've had multiple. Sandy Schremeyer, who runs the Facebook site for Live AFib Free, had atypical flutter after 3 ablations, and because we worked on the left atrium, that stopped it. It didn't stop it immediately. She still had it for a while, but by a year out from the mini-maze, it was gone. It burned itself out. So yes, initially I told patients when I started doing this 20 years ago, or over 20 years ago, this procedure, this mini-maze, I didn't call it a mini-maze then, a patient named it that, but this procedure is for atrial flutter. But as it turned out, it works very well for atypical flutter or left-sided flutter, which is usually the result of catheter ablation. What effects are people who have had the Wolf mini-maze experiencing post-COVID? Personally, I had many ectopic beats for COVID. Well, I just came from the cath lab. This is quite interesting. I just came from the cath lab here at Methodist, and I was talking to a patient of mine who had the mini-maze 12 years ago, and he got COVID, and then he had atrial flutter. And I said, you know what? There's another fellow in New Jersey that had the mini-maze 17 years ago, and he got COVID and he had atrial flutter. So this is anecdotal, that means we haven't done a study on it, but my anecdotal evidence is that there is a relationship between COVID and experiencing atrial flutter, atrial fib after not having it for many, many years after the mini-maze. So this also could be ectopic beats after COVID. And what is the mechanism? Well, studies have shown so far that both COVID and the COVID vaccine can result in myocarditis. Myocarditis, itis means inflammation, myocardio means heart. So it's heart inflammation. The heart muscle is not happy with COVID. It gets inflamed, swollen, and this can set off the fat pads. And these ganglionic plexi are embedded in the fat pads on the outside of the heart. So if your fat pads get inflamed around the outside of your heart, you can have recurrence, recrudescence of AFib. That's the way I look at it. And yes, I've seen more patients than I can name on 2 hands right now that have had some arrhythmia during or after COVID when they'd been fine for years. What do you do? Well, if you have atrial flutter, you should have a cardioversion, maybe go on antiarrhythmics for a few months. A lot of times it'll settle down because it's a temporary problem. Inflammation of the heart is usually a temporary problem, and if it settles down, then you should be all right again. If it won't settle down, this is the patient that I just saw in the cath lab, then the answer is to go to the cath lab. We've never had to redo a mini-maze. The answer is to go to the cath lab and have a catheter ablation that's very focused, and that's what Dr. Fahed saw today on this patient. The patient's from Tampa, Florida. There were places where he could burn a specific spot outside the area of the mini maze and completely stop this atrial flutter. So initially, if you have it after COVID, try antiarrhythmics, cardioversion if you can't get back in rhythm. And then if it still persists, then a catheter ablation is another possibility. So there are options, and you don't need a second mini maze. Next question. Would having a right bundle branch block prevent a patient from having the Wolf mini maze? Not at all. We see that very commonly. And maybe that's a good segue into an important point. The heart really has two systems, nervous system. One is the one you're born with, your pacemaker. And your pacemaker is not a nerve. Your pacemaker is a modified muscle cell. Arrhythmia surgery for AFib doesn't involve touching the pacemaker or the rest of the pacemaker, the right bundle, the left bundle, the Purkinje cells. That's not what we're dealing with. We're looking at the other part of this innervation system, and that's the ganglionic plexi, the autonomic nervous system, the nerves that make your hands sweat when you look over the edge of a tall building. Those are the autonomic nerves. The nerves that make your heart race when you're watching a scary movie. Why should your heart race? You're not running, but it does. These are the nerves that get active in stress, and they get overactive after many years of, I don't know, going to work every morning on a crowded interstate, working a difficult job. There are many stressors today, and the nerves can get overactive. If you have a partial denervation, those nerves settle down and the AFib goes away. Those nerves are different from the nerves of a bundle branch or the pacemaker. It's a completely different system. And the autonomic nerves are on the outside of the heart. That's what we're talking about. And they're really three levels. These nerves connect, they talk to themselves right on the heart. That's been well delineated in anatomy books and articles. And Dr. Miranda has talked about that on this show before. These little autonomic nerves also talk to your spine back and forth. And they also talk to your brain, to the hypothalamus. So it's a very redundant system bringing information to your heart for a good reason, because sometimes you want a fast heart rate right now. It used to be probably because you're trying to escape from a tiger. Now it's because you got road rage on the interstate. But the bottom line is it's the same thing, and overstimulation. Okay, so let me go mention again. These are great questions, by the way. If you have a question, pick up your phone, put in 37607, and then in the text box put DeBakey, and text in your message, your question. If you're on the on a computer, go to pollev.com. That's pollev.com. Enter DeBakey, and then respond to the activity and give us your question, and we'll do our very best to get to it. Mr. Producer, I gave you a little email I got just a couple of days ago. Maybe we should show that just as a little break, a nice little break in the action here. This is a patient who had the mini maze 6 months ago. He's not been in AFib since February 20th. We went to Switzerland and had a great time. I've hiked over 1,000 miles since surgery, several backpacking trips, hike up to 18 miles a day. You all really changed my quality of life. I can't thank you enough. Do I need to set up an appointment with you? Well, we do follow our patients at 6 months and then annually, especially if they have a link in. And he also sent us a nice picture. Were we able to bring that up? This is where he was. So I guess this is in Switzerland. It looks like he's having a pretty good time there. It's absolutely gorgeous scenery. A lot of times patients send me these type of reports because these are things that they were unable to do when they suffered from AFib. They were essentially grounded. They couldn't hike up mountains. They couldn't bike 50 miles. So the goal of the mini maze is to get you back in rhythm, get off the medicines, and get you back to doing what you like to do, whether it be hiking or biking. And yes, if you like to have a glass of wine in the evening, you can have one. If you like to have a cup of coffee in the morning, you can have one. You don't have to don't have to give those things up after you've had a mini maze. So let's see. Let's go to a couple more questions here. Are there any other surgeons doing the procedure outside of your facility? As an AFib patient, why don't we hear about this mini maze option? There are some other surgeons doing a similar procedure as mine, although they don't focus on the nerves. They focus on getting all the way through the heart muscle, which in my mind is secondary. The main thing is to focus on the nerves. But that doesn't include the convergent procedure. I don't think the convergent procedure, this is my personal opinion, is an ideal procedure for AFib. So the most common thing I see is patients advertise they do a minimally invasive AFib procedure, and yes, it's like the mini maze, and then we find out it's the convergent procedure. The convergent procedure and the mini maze are like apples and oranges. So it's important if you're doing your homework to try to figure out what you're going to do with your AFib. You have to really drill down and find out the facility you're looking at. Do they look at the nerves? Are they doing a convergent procedure, or are they doing a mini maze procedure? Mini maze procedure takes care of the nerves. Convergent does not. Why don't we hear about this mini maze option? Well, generally, first of all, cardiologists are trained as internists. They're not trained as surgeons, and they're not able to do a mini maze because they're not surgeons. They are allowed to put catheters in the groin. They're allowed to put in pacemakers, and those are types of surgery, but not any type of major heart surgery. They're not allowed to do it. And generally, I think sometimes if they don't do it, they don't think you need it. It's not something they offer. So they generally are going to give you what they offer. The mini maze is not 100% successful, but it's 100% more successful than a catheter ablation. The mini maze also takes some skill. Not everybody in the world has to do it, but there are skillful surgeons that can do it. One of the people that I trained, he was a fellow with me, Dr. Otsuka, who's in Tokyo, has now done over 2,000 mini mazes. And he does a very good job, and I've visited him multiple times since he started doing it. I'm the one who asked him to start doing it. It took me 2 years to convince him to get started, and now he does it all the time. He's very good at it, and he gets very good results, and he does it very minimally invasive. But I guess you could but it takes a lot of attention to detail. It's more of a high wire act than normal heart surgery. On normal heart surgery, with the breastbone open and the patient on the heart-lung machine, you have a safety net of being on the heart-lung machine. With the mini maze, you have to be pretty much perfect. But here at Methodist, we're perfect every day. We have fantastic results because that's what we do every day. Or you could take the basketball analogy. The Olympics weren't that long ago, and Seth Curry was a star. The guy can hit three-pointers from anywhere. And basketball's simple. All you have to do is put the ball through the hoop. Shoot it with one hand, shoot it with two hands, left-handed, right-handed, anywhere on the court. Doesn't matter. All you have to do is get the ball through the hoop. So how come not everybody's hitting three-pointers? Well, it takes some skill. Basketball is simple. That doesn't mean it's easy. And the mini maze is simple. That doesn't mean it's easy. But there are a lot of Seths out there, in my mind, that could do a very nice mini maze procedure. There aren't too many people that do it now. I think there are other reasons. Most heart surgeons are very busy already doing bypass surgery and valve surgery, and they don't really want to focus on arrhythmia surgery. That's what we do here at the Arrhythmia Center at Houston Methodist Hospital and DeBakey. That's all I do is arrhythmia surgery. So I'm a subspecialist, and I focus on it, but we do it very well that way. Let's do another question while we're on it. We're kind of on a roll here. We'll have Mr. Producer blow this up a little bit so I can see it. Oh, here's a little one before the big one there. What's your opinion of PFA? Oh, that's a good question. What's PFA? PFA is pulsed field ablation. Pulsed field ablation is a catheter ablation. But instead of using alternating current, it uses a direct current. So in other words, it's a little different setup of the electricity. It seems to be faster. It seems to be safer, but it does not seem to be more beneficial. And I predicted this because they're still burning with the catheter from the inside of the muscle towards the out, and the nerves are on the outside. And with pulse field ablation or PFA, they tout that they don't injure any nerves. Well, wait a minute. You better take care of the autonomic nerves, because that's probably what's causing and sustaining the AFib in the first place. So the midterm results, 6-month, year-out results of PFA or pulse field ablation for catheter ablation are no different than radiofrequency. No better. Do I think it'll be common to use PFA instead of regular catheter ablation? Yeah, of course. It makes sense. It's simpler, it's faster, it's safer, but it's not better. It's not any better than radiofrequency. Have you already done, or can you still do the mini maze in those who've had a pulsed field ablation, specifically if they're LAA or isolated during the ablation? The short answer is yes. And we've already done, I've done several patients, more than 10, that have had pulse field ablation, which tells you two things. One, we can do it, and two, the pulse field ablation didn't work. It made no difference. It was no better midterm than any other catheter ablation, be it radiofrequency or the freezing method of catheter ablation called cryoablation. So yes, that's fine. And it's not been any different as far as scar than what I'm used to seeing. Now, usually if the left atrial appendage was isolated, it means a watchman was placed, and we've done countless number of patients who've had a watchman. A watchman is kind of like a cork that goes inside the left atrial appendage. It is put in by a cardiologist and electrophysiologist through the groin, but it doesn't electrically isolate the left atrial appendage, and that's important because part of what has to happen is that you want the appendage to not have any electricity going through it anymore. And I've taken patients who've had a watchman, then we go for a mini maze. I put the probe on the appendage, and there's still signals in it, even though the watchman's in place. And I burn around the edge of where the watchman is, all the way around, and then there are no more signals in the appendage. So we've been able to sort of clean up a watchman and make it electrically isolated during the mini maze procedure. How can complications like fluid overload, pleural effusion, pneumonia, and pericarditis be prevented? Well, we do things to prevent those, but the risk never goes down to zero. No matter how carefully you drive your car, there's still a risk. It doesn't go to zero. So for the pericarditis, we give patients steroids after the procedure. We also use a gout medication after the procedure, and that dramatically decreases the incidence of pericarditis. Pericarditis is inflammation of the heart sac, inflammation of the pericardium, which is the sac around your heart, and all mammals have a sac around their heart, whether you're a mouse or a squirrel or a human. And that sac can get inflamed after any type of surgery, open heart surgery, minimally invasive surgery. And by giving steroids and anti-gout medication, it's dramatically decreased in incidence, but it's never zero. Pneumonia, again, very rare, but it can happen. Sometimes it's a pneumonia that got started before they came in the hospital. Pleural effusion, we decrease the incidence of that, which is a fluid outside the lung, around the edges of the lung, by leaving a tube in overnight to drain any fluid. Usually after 24 hours, that fluid is not going to reaccumulate, but it's never zero. Sometimes it can. Is there something we can do as patients in preparation for the mini-maze in order to make these complications less likely to happen? Yeah, the main thing is try to have a normal body weight. So morbidly obese patients have more trouble recovering from orthopedic surgery and also heart surgery. So if you're overweight, the most important thing you can do is get your weight down for two reasons. You'll be able to get around better afterwards, but maybe more importantly, the procedure itself is easier to perform for the surgeon if you've lost weight. So I don't think the low sodium diet is the key, or liquid diet. It's losing weight. If you're in a normal body habitus and you get up and walk the day after the procedure, you'll be out of the hospital in 1 or 2 days after the procedure, and you'll do very well. 70% of the patients who have the mini-maze do not take narcotics post-op. It's not 100%. 30% still do, but 70% don't, which is pretty good after heart surgery. Mr. Producer, is that the last question on that one, or we're good? We caught up? Okay, so one last time, if you got any final questions, go to 37607, put in DeBakey, or go to pollev.com and enter DeBakey. We've talked about a lot of different things here. We mentioned a patient who came here who'd had 8 ablations and now is in rhythm. There was another patient from Long Island who had 5 ablations, was told not to come here, came here and had the mini-maze and is in rhythm. So I don't know what the limit is, but we have very good success with patients who've had multiple ablations. It does make the mini-maze technically more challenging, just because there's scar there after that many ablations. Well, let's try to get through a few more, I guess, before we finish the hour out. Does the mini-maze only work on those who have vagal AFib? Mine doesn't seem to be related to food, drinks, or position. Does the pericardial sac remain open forever after atrial clip placement? Okay, good questions. I think everybody who has lone AFib has vagal AFib. Whether you have nailed down your symptoms and your triggers or not. AFib is related to the autonomic nerves that are giving signals to your SA node and your bundle branches, and you got to decrease those signals from the autonomic nerves. So it only works on those who have vagal AFib, but I think that's everybody. That's my opinion. Although there is a video that doesn't show the heart sac being closed on YouTube. It's an old video of mine. It must be, gosh, 15, 20 years old now. In fact, we do close the heart sac during every procedure. That video was already about an hour long, and we took some things out. But the pericardial sac does not remain open, and we close it over the clip routinely every day. So the pericardium is reapproximated, is the surgical term at the end of the procedure. Dear Dr. Wolf, I live in California. I would have to fly in, and how many days pre-op, stay in hotel and stay, and how many days post-op? Medicare pay for the procedure? Thank you. Medicare has paid for the procedure for many, many years. No problem. Unless you got some weird Medicare plan, but the best Medicare is just straight, regular Medicare. You can come here from anywhere in the United States and Guam and other places with just straight Medicare. What people usually do is they fly here 2 days before the procedure, meet me, meet Kimberly, have the pre-op testing, which includes a CT scan to make sure there are no blood clots in the heart and make sure the coronary is okay. Then have the procedure, stay in the hospital, usually a couple days. Some patients go home after 1 day, and some patients go home after 3 days. Most commonly, patients go home after 2 days. Last week we did 6 cases, Monday, 2 on Monday, 2 on Tuesday, 2 on Wednesday, and everybody was out of the hospital by Friday. That's what we like to see. Now, so that's 2 days before, 2 days in the hospital, maybe 3. And then I like patients to be about a week out before they fly back to California or wherever. The reason being, I'd like to see in the office, make sure you're walking around okay, the incisions look okay before you fly away. Because once you fly out, it's a lot harder to take care of any issues. So as a routine, I try to see patients 6 or 7 days after the surgery. So you add all that together, you're talking about 10 days stay in Houston. But it's a nice place. There are lots of things to see and do, and there are over 10,000 restaurants in Houston, which doesn't go very well with what I just told you before, which is you should try to lose weight before the procedure. But after you're here, then that's a done deal. I told my cardiologist about your procedure. They said it would be better to put in a pacemaker and control AFib with meds. Your opinion? Oh boy, now you're hitting me right where it hurts. In my opinion, AV node ablation and pacemaker is a terrible option for treatment of your AFib. It doesn't stop the AFib, and 25% of patients who have a pacemaker have pacemaker-induced heart failure. And then you're totally dependent on a mechanical, electrical pacemaker. It makes no sense to me at all. This was an option when we didn't have other options. But don't do that. Talk to me, get a virtual visit. You're much better off getting something done about it. Pacemaker and AV node ablation is your last option. This fellow who came from Australia, he was 44 years old, he had 2 failed ablations. They told him he needed a pacemaker and just control the AFib at 44. Really? No, that's not a good option. Does the Wolf mini maze do something with the vagus nerve to address AFib? Oh yeah. These are the little branches of the vagus nerve called the autonomic nerves, the ganglionic plexi, and that's what we focus on with the mini maze, and it works. You mentioned the mini maze corrects high blood pressure. Oh, does that happen right away or does it take months? Okay. Well, we have noticed, as have others, that if the left atrial appendage is closed in patients who have high blood pressure or hypertension, that many of them have a normalization of their blood pressure. And this is because in the left atrial appendage, there are some hormones that are secreted that tend to make your blood pressure high. So if the appendage is closed, it can normalize the blood pressure. It seems to happen right away. So if someone's on high blood pressure medicine before the mini maze, we do not continue it after the mini maze, or at least cut it in half, because many times you don't need that medicine anymore. It's not 100%. Some people still need their blood pressure medicine, but a lot of patients have a much better blood pressure profile after the mini maze. Ladies and gentlemen, it's 5:54. I've been talking continuously for 54 minutes, which I could go on, but I know the producers want to go home and watch the debate tonight, and hopefully you will too. So I'm going to wrap up this session. They've all been great questions. There's even more coming in. Leaky valves. Well, as long as it's not a really bad leak, we still do the mini maze. Leaky valves usually aren't addressed unless it's a severe leakage, but mild or moderate, we still do the mini maze. If the left atrium is greater than 200 milliliters, the chances of staying in rhythm start to go down. With the mini maze, we measure the volume of the left atrial appendage with the CT scan pre-op. And I think we better stop there. Thank you all for tuning in. This will be available right after the live performance. If you'd like to go back and look at segments where you missed it, you may do so. I hope everybody has a good evening. We're back on track. So Mr. Producers, we'll be back again in a month on Tuesday, right? First Tuesday of the month, unless you hear otherwise, right here in Houston, Methodist Hospital, DeBakey Heart and Vascular Center. Thank you all for listening. Have a good evening. Goodbye.